Hello there, I'm Jenny Bosch. I'm a member of the Board of Directors of the Sydney Orthopaedic Research Institute, and we're here today at the SORI offices in Chatswood to talk to the three directors of the Institute, Dr. Miles Coolican, Dr. David Parker and Dr. Brett Fritsch. Miles, when you see a patient with knee arthritis, what factors help you decide whether a knee replacement as opposed to offering non-surgical treatment is the answer?
Well, there are many factors that help a surgeon decide whether or not they're going to operate on a patient with knee arthritis. Probably the first one that's most significant is age. We tend not to want to do knee replacements in the younger patients. We tend to be more inclined to do them in the older patients. I mean, there are many reasons for that, but the simplest one is that if we look at revision rates in the younger group, they're higher. Younger people wear them out faster. So we're probably inclined to do sometimes other operations for the younger patients with knee arthritis. We might, for example, unload one side of their knee by changing the alignment of their leg. Whereas an older patient, we would not do that. We'd more likely do a knee replacement. And then, of course, there are issues related to the severity of arthritis, the severity of symptoms. And when there's a mismatch between the patient's symptoms, lots and lots of pain, but not much wear and tear, one's got to be very careful in recommending knee replacements because those patients have a much higher chance of being dissatisfied. And in the finish, the biggest factor in determining whether we decide to operate on a patient and replace their knee is, by and large, the severity of the wear and tear on radiographs. The knee's worn out and the symptoms that the patient have match that wear and tear, and their disability is significant, their life isn't the way it wants to be, and their expectations of improvement are appropriate to what you think you can deliver with a knee replacement, then we proceed.
Mm-hmm. Thanks, Miles. David, you set up the Sydney Intensive Knee Clinic as a means of treating patients with the symptoms of knee arthritis that were not yet considered severe enough to proceed with, say, knee replacement. Tell me about the rationale for starting the clinic and the treatment options that you offer and what sort of outcomes you're achieving.
Well, knee osteoarthritis is a very big problem within our community. It's very common. And in reality, we have very limited surgical options that are indicated. We know now from a lot of studies done over the last 10-15 years that doing an arthroscopy, a keyhole surgery for knee osteoarthritis is not helpful for patients, despite the fact that it's been the most common orthopaedic procedure done in the last 20 or 30 years. And there often is an expectation from patients that when they come to see us, that's what we'll do. We'll do an arthroscopy, we'll tidy up their knee and they'll be fine. But if we look at the evidence behind that, except for a very small, limited number of cases, that's not appropriate. It doesn't help patients and has been shown to be not any better than good non-surgical treatment. And then we have a limited number of patients that we can do a realignment or a reconstructive procedure. And then when patients get to the end stage of osteoarthritis, we can do a knee replacement. And we don't like to do that before they get to that stage for the reasons Miles alluded to before. So we have this huge volume of patients who have a problem. They have a painful knee, they have osteoarthritis for which surgery is really not appropriate. And we need to offer them a solution that they think can actually work for them, that they understand, that has an evidence base. And there are a lot of non-surgical treatments that have a good evidence for helping patients. We explain to patients there's no cure, that we can't reverse their condition, but we can manage it better and we can help them lead a better quality of life. So there is evidence around treatments such as good exercise programs delivered appropriately, bracing, injections, medications, modifications of their lifestyle. There are so many things that we know can benefit, but if we just tell patients briefly, it's very hard for them to understand and apply this in an effective manner. So a few years ago we decided that we needed to offer these patients a solution. So we set up essentially a multidisciplinary non-surgical clinic. So we can see each patient, we can give them the education to understand their condition, and we can devise a program that has an evidence base that's going to work for them. And so that's what we've done through the clinic. The clinic has grown quite a lot over the last 2 years, and we've been very happy with the outcomes of the clinic to the point where we see the need and the actual demand has outgrown what we can supply, so we're going to expand this further. And it's really, I think, important that we are able to provide these patients with a solution that's effective for them. And the other side of the coin too is often these patients will one day be appropriate for surgery. And if they're managed well non-surgically, we know that helps them put the surgery off longer, and when they come to surgery they will understand the process better and they will get a better outcome. So that in essence is what we're trying to do with a non-surgical clinic.
Right. Thanks, David. Brett, what do you think are the key factors in success generally in knee surgery?
I think in general terms, you get a successful outcome if you do the right procedure, done the right way, in the right patient, at the right time. So it's about getting all those factors aligned to get the best possible outcome. So, as the surgeon, we put a lot of attention into the surgical technique and the way we do the operation. But it's just as important to select the patient that's going to benefit from that procedure in the best way. As Miles and David have alluded to, there are many different options, from the non-surgical options through to some conservative joint preserving type procedures through to knee replacement if we're talking about osteoarthritis. And finding the right procedure for that particular patient with their level of disease, their expectations, their comorbidities, their lifestyle, doing it at the time that's most likely to give them the best outcome, not doing it too soon, where something more conservative would be a better option, and not doing it too late when you're not going to any advantage of waiting any longer. So picking that right time to do the procedure. So lining all those factors up gives the best results, and that's why a lot of the research that we do here and a lot of our programs cover that continuum from very early stage through to end stage treatment, and good data collection, monitoring all the way along to line up all those factors.
Okay, thank you. And David, coming back to you, how do you use evidence to make decisions? And these days, how can patients distinguish from all the noise that's out there on social media and advertising to make a good decision?
It's a really good question, and as a patient in this current time, there's a lot of information out there, and it's generally pretty common that patients will do their own research. But it's very hard for them to have any gauge on what the level of evidence is. And, the majority of the information that will be in social media on the internet has a direct intention of trying to promote something, not necessarily because it's in the best interest of the patient. I think as doctors, we have a responsibility to make our decisions based on evidence and based on clinical work, experience, research. So we actually know that what we're telling a patient, the advice we give a patient, is actually true, and we can reassure the patient that it actually is based on evidence and not necessarily based on trying to promote ourselves or a particular technique or anything that may be not necessarily in their interest. So we do a lot of research here, we follow up a lot of our patients, and the only way that you can really understand your outcomes and learn from those outcomes is to follow up your patients, to investigate your patients, to talk to your patients, to follow them for a long period of time and really understand the outcomes of the procedure. I think there's obviously a big tendency when people are trying to promote something, they will really just talk about the good results and they will ignore the other results. And I think if everybody is honest with their results are not always perfect, and it's often the imperfect results that we learn from. So having an evidence base to what we do is absolutely critical if we're going to practice medicine properly. And if patients can actually trust us when we give them an opinion and we give them advice on what they want to do.
Indeed, thank you. You've all treated patients who've ended up less than satisfied with the outcome. Brett, I know you've conducted a study into those patients. What did you find, and what sort of conclusions have you reached about doing things differently?
Yeah, well, the study you refer to, Jenny, is about total knee replacement. And knee replacement is a good operation, and the results are generally good. But if we have a look at the published results, and a lot of people publish in this area about how their patients are actually satisfied with the outcome and how many of them achieve the expectations they thought they were going to. The quoted numbers frequently about 80% are satisfied, which leaves about 1 in 5 in the worldwide literature is described as being not as satisfied with their outcome as they thought they'd be. So we thought we'd have a look at our results. And in about 400 patients that we look back on, we saw that about 6% of our patients were less satisfied than they thought they'd be with the knee replacement. So we thought we'd drill down a little deeper into that 6% and see if we could find out what it was that was driving that and what we could do to alter it with our future patients. So when we looked at them, the knee replacements themselves were the same in the patients that had had a good result, the satisfied 94%, and the dissatisfied 6%. So we couldn't see any differences in the way the operation was performed, complications, alignment, the implants, all the surgical things that we can control looked the same in both groups. So what was it that was different in those 6% of patients? And what we found was there are different characteristics that seem to align with a higher chance of being in that group. And the first one would be the patient's expectation. So it's important to realise that what we're trying to do, we're not trying to give them a knee replacement, we're trying to give them a knee that achieves what they want. And so it's important to have an alignment between what we can actually achieve with a mechanical operation to replace a damaged knee and what the patient thinks we're going to be able to achieve with that. So getting those expectations aligned is a critical thing. So if there's a mismatch there, you tend to see a higher rate of dissatisfaction. The other issues is how they get through the procedure and through the process. The operation takes us about an hour to do a knee replacement. That's almost the easy part. From a technician's point of view, we do lots of knee replacements. That's the easy part. But managing them pre-operatively and post-operatively requires dealing with a person, not just the knee. And people differ vastly in how they approach it from an anxiety point of view, how nervous they are about the procedure, how anxious they tend to be in general. So patients that have higher levels of anxiety tend to find it a little harder to recover and report slightly higher levels of pain or dissatisfaction with their knee. How they get through doing their prehabilitation and post-op rehabilitation is an important thing. And simply how they view their healthcare. It was an interesting finding. There's a thing called the Locus of Control, which is a fancy term for saying how much do they think the way they're contributing to the outcome is important versus how much someone else is adding to the outcome. And those patients that had a high locus of control that felt like this is something I can get myself through, I'll get through the procedure, I'll get a good outcome, they get a good outcome. Those that sit back a little bit and say, well, I've got a damaged knee and you fix it, the surgeon fix it or the rehab team fix it, give a little more of that control away, they actually were more overrepresented in the group that were dissatisfied. Everyone experiences pain differently, and you experience pain in different contexts as well. I mean, if you're playing a game of football and you get tackled, it really doesn't seem to hurt so much. But if you get tackled walking down the street, it's a completely different thing because it's in a completely different context. And patients report pain differently and experience pain differently in different contexts, including around knee replacement. So there are ways to measure that. We had them fill in a questionnaire that gives us some idea on how sensitive they are about reporting pain. It's called a pain catastrophizing score, which is simply a way of trying to quantify how do I feel pain versus somebody else. And we found some features there that if they had higher levels of reporting pain in most contexts, then it's likely they're going to report more pain after a knee replacement if they still have any residual discomfort from time to time. And that tended to correlate with a higher level, a more frequent representation in a dissatisfied group. So some of these personality factors, expectation factors and psychological factors that a surgeon, it's easy to ignore. You've got a bad knee, you need a knee replacement, I can do that procedure, we can do it well. But we see that they're very important in patients' outcome. And so it's kind of a transition away from knee replacement as a isolated procedure to knee replacement as a process. Part of the, we've talked, all three of us are talking about the continuum of care of osteoarthritis, and it's addressing all those factors to get a higher level of outcome.
One of the things we haven't talked about is the impact of rehab. I wonder if you'd like to comment on that.
Sure. I think when you mention rehab, I presume we're largely talking about after knee replacement surgery. And I think that the point that we make to patients is that rehabilitation is critical. It's obviously very important to have the appropriate goals and have an understanding of what you're trying to achieve. And as Brett alluded to before, and as I think Miles has said as well, selecting the right patient at the right time, doing the procedure well, creating the right expectations is very important. how they recover afterwards is particularly important. There's been a lot of research and talk in media and other circles recently about the need for staying in hospital to do your rehabilitation, so inpatient rehabilitation, and in a lot of places around the world they've even been doing knee surgery as an outpatient, so day surgery. So I think if we look at all the research into rehabilitation, there is no proven benefit for patients to stay in hospital. They don't get better outcomes if they stay in hospital. That doesn't mean that nobody needs to do that, but it's really driven by the individual requirements of the patients. And the trend these days is to try and get people to rehabilitate quicker, to get them out of hospital quicker, and that's largely in their own interests. So most people, if they manage their pain and their swelling after surgery, they do a simple exercise program, will rehabilitate well. And so I think patients need to have a good understanding of what their goals are, but we're moving away from the obligation that people feel that staying in hospital is critical to your outcome, because it's not. People can get a very good outcome, and really the only reason people need to stay in hospital for an extended period is if they have difficult circumstances at home, but it's not really going to make any fundamental difference to their outcome.
Thank you. And Miles, can you tell us why you and your colleagues decided to invest your time and efforts into the Sydney Orthopaedic Research Institute, and what are your goals?
As part of our training, we were encouraged to do some research, and it became, over the years, almost compulsory, and now it is compulsory for orthopaedic surgeons to do some research as part of their training, otherwise they're not allowed to sit the exam. So in my training and with David's and Brett's, we did some research and we liked it. We got a taste for it, and we realised that it was going to improve not only the outcomes that we would achieve, but if it was good research that gave answers to questions that weren't already known, that we would help all of the orthopaedic community to do better work. So the goal of research by and large is to look at the ways we do things and determine if there's a better way, and sometimes that might involve a study of two different arms, two forms of treatment, or it might involve just looking at the results of our work and seeing what does better. But that doesn't just happen. It takes people, it takes money, it takes time and effort and energy, not just from us, but from our patients as well. And in order to achieve that, when David joined me in practice, it became clear that we needed to start an organisation that would help us do this. And that's why we started SORI back in 2001, 2002. The goal for SORI, quite simply, is to provide better information to the orthopaedic community about knee surgery, so that the outcomes are better for our patients. We started it in 2001, 2002, and we've continued, we've grown, we've added Brett, we've had research staff, we've put our finances into it, and we came to recognise very quickly that if we were going to collect data on our patients, the facility needed to be co-located to our office. So we have SORI with our office, with our staff, and in a current to that, we've had fellows that have come from around the world to work with us, and that's given us relationships with orthopaedic surgeons in many countries, but in particular in France, in Britain, South America, New Zealand, the United States, Canada. We've had fellows from all over the world, and it's been a source of great joy for us that we've been able to educate other people, and they've participated in our research as well.
That's great, thank you. And thanks, Miles, David and Brett, for the conversation today.